In the previous lecture, we saw how it all started with penicillin. You know already that penicillins, cephalosporins and carbapenems all share a similar structure and the same mechanism of action. Their core is always a beta-lactam ring, and that is why they are collectively called beta-lactams. Now let's focus on cephalosporins and see how they are different from penicillins. Just like penicillins, cephalosporins are divided into different groups or generations. But first, let me get this out of the way. If you try to memorize all cephalosporins, you will probably quit, flip out, burn your textbook and throw your laptop out the window. Fortunately, as a clinician, you don't need to do that. In practice, you will probably only use 3 to 5 of these drugs, maybe even less, because many of the drugs that are listed in textbooks are either obsolete, not widely available, or they simply confer no additional benefit to the drugs that we are about to cover. So let's start with the first generation. You should view these antibiotics as an alternative for antistaphylococcal penicillins. If you're a patient with a staphylococcal or streptococcal infection, usually a skin or soft tissue infection, right, cannot receive antistaphylococcal penicillins due to allergy or for whatever reason, first-generation cephalosporins might be a viable option. Many studies have shown that first-generation cephalosporins are equally effective as antistaphylococcal penicillins for the treatment of skin infections and even severe staphylococcal infections like sepsis and endocarditis. Just don't forget that, just like penicillins, they do not work against MRSA. The ones that are most commonly used are cefalexin and cefadroxil, which are administered orally, and their intravenous counterpart is cefazolin. The main difference between first-generation cephalosporins and antistaphylococcal penicillins is that the former have a somewhat broader spectrum of activity. Cephalosporins do have at least a modest gram-negative coverage. In short, they cover E. coli most of the time. And this is why in some guidelines, in some fortunate parts of the world where the resistance rates of E. coli are still under control, you may find cefalexin as an option for the treatment of mild urinary tract infections like cystitis. But nowadays, the resistance rates of E. coli, not to mention other gram-negative bacteria, in many areas of the world are too high for cefalexin to be a viable option. Your local resistance rates are always paramount. Again, in simplest of terms, you should mostly view first-generation cephalosporins as a great alternative to antistaphylococcal penicillins. You don't want to use them for respiratory, so pneumococcal infections, and certainly not for anaerobic infections. Cephalosporins in general do not work against anaerobes, remember this. First-generation cephalosporins will reliably kill group A Streptococcus, methicillin-susceptible Staphylococcus aureus, wild-type E. coli, and that's about it. So let's move on. You may find in your textbooks that the further you move up the generations of cephalosporins, their gram-positive coverage becomes weaker while their gram-negative coverage improves. While that, I'm afraid, is an oversimplification, and you will see what I mean by the end of this lecture. I'm always a fan of simplicity, but this notion simply doesn't fit reality. Now let's take a look at the second generation of cephalosporins. The most well-known representative of the second generation is cefuroxime. It's available in oral and IV formulations. Its spectrum of activity is quite similar to the first generation, but with one crucial difference. While the first generation is generally useless against pneumococcus, cefuroxime does have a decent pneumococcal coverage. By decent, I mean, if pneumococcal resistance to penicillin is rare in your area, cefuroxime can be a good second or third line option for mild pneumococcal infections. But in areas where pneumococcal resistance is more common, it's just too risky, so don't use it. Pneumococcal resistance to penicillins spills over to earlier generation cephalosporins, especially oral versions, so generally speaking, cefuroxime is rarely the best option for bacterial respiratory tract infections. Actually, it's rarely the best option for anything. First-generation cephalosporins are better against Staphylococcus aureus, and later-generation cephalosporins are much more active against pneumococcus and gram-negative bacteria. So let's move to the third generation. Now, this generation is by far the most complex, and the drugs within this group are so different from one another that, honestly, putting them into the same group doesn't really help us in any way. In my opinion, it's best to view the few most important ones separately. By far the most popular, most overused, and most versatile drug in this group is ceftriaxone. You will find it in many guidelines for the treatment of pneumonia, otitis media, urinary tract infections, and even bacterial meningitis. And there are many reasons for that. First, its spectrum of coverage. Being a later generation cephalosporin, yes, it does have a good gram-negative coverage. It will work against most isolates of E. coli in most areas of Europe and the United States, although local resistance rates can vary, of course. But what about its gram-positive coverage? Is it true that it is inferior to first-generation cephalosporins? Well, yes, it is less active against Staphylococcus aureus. Therefore, it should not be used to treat severe staphylococcal infections like sepsis or endocarditis if you have another choice, and you usually do. For mild staphylococcal infections like cellulitis, it should be okay. But why use it even for that if you have other, better options with a narrower spectrum? Bottom line, ceftriaxone should not be your first choice for the treatment of staphylococcal infections. What about other gram-positive cocci like streptococci? Well, this is where ceftriaxone absolutely shines, and this is where this false, oversimplified notion that somehow later generation cephalosporins are not as active against gram-positive cocci as the earlier generations quickly falls apart. Ceftriaxone is highly effective against all streptococci, including Streptococcus pneumoniae, even most strains that are resistant to penicillin and earlier generation cephalosporins. It's much more active against Streptococcus pneumoniae than the earlier generations. And as opposed to them, it can even cross the blood-brain barrier. And when you put all of this together, its coverage of Streptococcus pneumoniae and other bacterial respiratory pathogens, including other streptococci and other bacteria we will mention in later lectures, it's no wonder that ceftriaxone is highly effective in the treatment of bacterial pneumonia, bacterial sinusitis, and otitis media. And since it does penetrate the blood-brain barrier really well, it's also a great choice for the treatment of bacterial meningitis, which is most commonly caused by, again, Streptococcus pneumoniae. Another convenient characteristic of ceftriaxone is the fact that it's only administered once a day for most infections except central nervous system infections, which makes it an ideal option for outpatient treatment. So the patient comes in once a day, they get their ceftriaxone and they go home. They don't need to be hospitalized. Yet another significant advantage of ceftriaxone is that you don't need to adjust the dose for patients with renal failure. Most beta-lactams are eliminated exclusively through the kidneys, but ceftriaxone is also excreted in the bile, so the biliary system acts like a safety valve, let's say, for patients with kidney dysfunction. All in all, in many ways, ceftriaxone is really a great drug. No wonder then that this antibiotic is so popular and even overused. Cefotaxime is another widely used third-generation cephalosporin, and its spectrum of coverage is almost identical to that of ceftriaxone. The major difference is that it's not as convenient as ceftriaxone, since it needs to be administered several times a day. But now we come to a third-generation cephalosporin that truly does correspond to the textbook stereotype of being great against gram-negative bacteria and pretty bad against gram-positives. And this is ceftazidime. Not only does it work against most isolates of E. coli and its close relatives, but it even has anti-pseudomonal activity, something that other members of this group don't have, not even ceftriaxone. And this is why we use this antibiotic only when we are concerned about possible infection with Pseudomonas or other resistant gram-negative rods. Now, there are also oral third-generation cephalosporins that you can use to treat patients who don't require hospitalization or intravenous drugs. And if you want a maximum oversimplification, you can view all of them as oral and somewhat weaker equivalents of ceftriaxone and cefotaxime, but in my opinion, there are some important differences between them that the clinician really should know. It's best to classify them according to their use. Cefpodoxime and cefdinir are more suited for treating respiratory tract infections, while cefixime and especially ceftibuten are better for urinary tract infections. Let me explain. For respiratory infections, cefpodoxime and cefdinir can truly be viewed as oral equivalents of ceftriaxone. Most of the time, they should be quite effective against the usual culprits for bacterial respiratory infections like, first and foremost, of course, Streptococcus pneumonia. And in most areas, they are viable as a second or third line option for the treatment of mild to moderate cases of sinusitis, otitis media, even bacterial pneumonia. Now, why did I say second or third options? Well, because we generally prefer to use penicillins like amoxicillin if it is possible. Amoxicillin has a narrower spectrum and it's equally effective. It kills what it needs to kill without wiping out everything in its path, including the patient's gut microbiome. More on that when we discuss respiratory infections specifically. Just keep in mind that pneumococcal resistance to these oral drugs is somewhat more probable than resistance to their intravenous counterpart, ceftriaxone. Therefore, for patients with very severe symptoms, if you choose to use a cephalosporin, it's probably better to go with ceftriaxone as opposed to these oral drugs, at least in the beginning. Now, regarding their gram-negative coverage, it isn't bad, and they can be a viable option for the treatment of urinary tract infections, depending on your local resistance rates. But why bother with them if there is a little better option from the same class? Namely, ceftibuten is much more active against many gram-negative rods, which makes it an excellent choice for the treatment of urinary tract infections. Its gram-positive coverage, however, is really bad, so you definitely don't want to use ceftibuten to treat respiratory and skin and soft tissue infections. Cefixime, the fourth member of this group, is somewhere in between, although for practical purposes I would put it closer to ceftibuten, so for urinary tract infections. Its good gram-negative coverage makes it a good choice for mostly uncomplicated urinary tract infections, and it also has a solid gram-positive coverage, which makes it a very popular choice for all sorts of infections, but I would say it's overused in that regard because for gram-positive bacteria, there are simply better options, and cefixime should definitely not be the first choice for the treatment of pneumococcal and other streptococcal infections, and certainly not for infections caused by Staphylococcus aureus. So much about the third generation. Fortunately, the final two generations of cephalosporins are much simpler to memorize, and you can view them as a secret weapon for the most problematic pathogens, Pseudomonas aeruginosa and Staphylococcus aureus. In the fourth generation, there is cefepime, and in terms of antimicrobial coverage, cefepime is something you get when you mix all the third generation cephalosporins together. It's a love child between ceftriaxone and ceftazidime, so it covers everything ceftriaxone would cover, and in addition to this, it has superior gram-negative coverage that also includes Pseudomonas. The fifth generation is a very weird group, but all you need to know is that ceftaroline and ceftobiprole are the only beta-lactams for now that cover MRSA. Yes, MRSA. So, in simplest of terms, you can view them as ceftriaxone with MRSA coverage. We will talk more about them when we discuss staphylococcal infections specifically. The final member of this fifth generation I think you should know about is cefidroxil, and this one is quite different from the previous two. You will not use it to treat MRSA infections because its gram-positive coverage is terrible. Instead, it covers the most problematic gram-negative pathogens, including many multi-drug resistant strains of Pseudomonas, Acinetobacter, and even bacteria that produce the most powerful beta-lactamases that destroy other cephalosporins, penicillins, and even carbapenems. In short, you can view it as ceftazidime on steroids, ceftazidime with an even broader gram-negative spectrum. We will talk more about this drug in the lesson on hospital-acquired infections. To summarize, first-generation cephalosporins are like anti-staphylococcal penicillins, only with a little bit of gram-negative coverage for wild-type E. coli. The second generation you may use for mild pneumococcal infections and even UTIs, but only if you live in an area where resistance rates of Streptococcus pneumonia and E. coli are low. In the third generation, ceftriaxone and cefodoxime have much better pneumococcal coverage than the earlier generations, and they are also more active against gram-negative bacteria like E. coli. They cross the blood-brain barrier very well, which makes them suitable for the treatment of bacterial meningitis. In the third generation, ceftazidime stands out with even better gram-negative coverage that also includes Pseudomonas, but its gram-positive coverage is terrible. In the fourth generation, there is cefepime, and you can view it as a mix of ceftriaxone and ceftazidime. In the fifth generation, ceftaroline and ceftobiprole are like ceftriaxone, only with MRSA coverage, and they are still the only beta-lactams that cover MRSA. Cefidroxil is a fifth-generation cephalosporin that is like ceftazidime on steroids. It has excellent gram-negative coverage that includes many multi-drug-resistant pathogens. I know that the names of cephalosporins are frustrating and terrible, but if you use them, you will remember them, and the ones that you don't use, who cares? Print out your PDF summary, put it right below the one with penicillins, and let's move on. Now to the most powerful and the simplest, fortunately, group of beta-lactams, the carbapenems.